Hello, everybody. It's a pleasure and an honor to talk to you today on the problem of doing things in the ICU. My theme of today is just do something, don't do something, but stand there. That will be the central theme of my presentation. These are my disclosures. None, in fact, of them is relevant to this particular presentation. So last year at the ISICEM meeting, I did a talk on watchful waiting in suspected infection. And the conclusion was that in some situations, if you're not sure and if the patient is stable, then it's okay and maybe better in some situations just to wait and reevaluate the patient at a later stage. And that made me thinking. And shortly thereafter, I heard about this study, and you may have seen it or heard from it in the lay media. This was a study looking at mortality in cardiology patients, acute myocardial infarction mortality, when the interventional cardiologists were away for the meeting. And in fact, they found that mortality during this time was lower. And this made me think, is this concept of not doing something, just waiting, setting a step back and reevaluating a patient at a later stage, is this something that applies in other situations in the ICU? And this is what I would like to discuss with you today. Of course, we need to look at the background and we need to consider the situation where we actually are in right now. We live in a fast-paced society. We want instant responses. We want instant gratification. And social media, for instance, is a very nice example. We want to see replies and likes within minutes or hours, but not days or weeks. So you're really rigged for fast response. And probably also our processes in the ICU, if you look closer at them, have a little bit of the same thing. They are aimed at speed. Speed is the central issue. We want fast track for surgical procedures, for ICU discharge. We want rapid diagnostics. We want continuous monitoring, not because we're just not able to wait until the blood gas analyzer, for instance, gives us the results. And this is now also starting to impact education and practice. Of course, there's also some pressure from society. People look at the TV where they see within 15 minutes diagnosis and treatments being finalized and patients leaving the hospital. And people expect the same from us. So what we want actually is instant diagnosis. It's a bit like instant coffee. And well, if you compare instant coffee to the real thing, you know it really just doesn't live up to it. So let's take a closer look at processes in the ICU. Now, the ultimate goal on the right-hand side is to improve outcome in our patients. And this is something that we, of course, should be considering at every step. It starts with a trigger, something, and I'll elaborate a little bit on that. Then we do a test, we may do a test, we make a diagnosis, we link a treatment to it, and all of this with the intention to improve outcome. But the question is, at every step in this diagnostic process, how good are we? And I'm just giving you one example, something very common that you will certainly recognize. When the nurse reports a decrease in urinary output, that would be the trigger, an observation. Right? We may do a test or may not do a test, but well, we easily come to a diagnosis. For instance, this patient is hypovolemic, this patient needs a fluid bolus, and we just assume that by doing something, this will improve the outcome of our patient, this will benefit our patient. But this is really the question. Maybe we should, at some point in this process, take a step back and just say, well, what is happening? Of course, if there's something very important acutely, if the patient is acutely deteriorating, then we need to look at the patient. But in some situations, it may be as adequate to just wait a few hours, come back, reevaluate the patient, and see if the situation has improved, or indeed if the patient needs an intervention. So what could be a trigger in our ICU? So it could be patient signs and symptoms. That's very obvious. Patient complains, I have pain, for instance. But it could be also clinical examination findings. When we do a clinical examination, we find something, and this may trigger a test, or this may prompt a diagnosis. It could be a nurse or other healthcare worker that alerts you to something. They've observed something during the care for the patient. But often it may also just be abnormal numbers that come from our routine monitoring and our routine continuous monitoring in many patients. But also, and this is happening all too often, I think, it comes just from doing routine things, routine blood sampling, routine x-rays, routine this, routine that. And this then leads to another test, may lead to a diagnosis, correct or wrong, and then potentially to a treatment that may be harmful. And this is really an issue that is very important in our ICUs, and we are really prone, much more than any other specialty. We have a lot of numbers in our ICUs. We have a lot of monitors. And look at your own ICU, and probably every year you will have a new monitor, or you will have an updated version of a previous one that gives you even more online numbers. And the question is, what do we do with it? We have access almost to unlimited testing in our ICUs, and that decreases the threshold to actually do these tests, which may find something that is not really actually helpful for the patient. Is it because we just blindly believe our tests? Do we think that every test is 100% reliable? Well, we shouldn't. You know very well that every test has its specificity and its sensitivity. And much depends also on the pre-test probability. And if you just do routine testing, then certainly some things will pop up, but many of them will actually be quite irrelevant. So always consider this sensitivity, specificity, and the pre-test probability when ordering or thinking of a test. Never, ever do a test to confirm a diagnosis. Why would you do a CT scan to confirm acute pancreatitis if the clinical picture and the lab values are actually enough to make the diagnosis? Okay, you may want to screen or to look for complications thereof. That's different, because if there is a complication, then that may need a treatment. But a lot of CT scans in the situations are just done routinely to confirm the diagnosis. If a diagnosis is deemed to be irrelevant for that specific patient in that situation, well, don't do the test. If it doesn't bring anything, why would you do it? We could do a prostate-specific antigen in any patient in the ICU, and certainly will diagnose prostatic problems, but why would we do it? The ultimate question you should ask yourself is this test fit for this patient in this particular setting? And if we would do this in every patient, we will already eliminate a lot of the tests we do in the ICU. And this brings me to the problem of overdiagnosis. Overdiagnosis is a very important problem in the ICU as well. It's a diagnosis, it's a correct diagnosis. It's not misdiagnosis, but it's a diagnosis that is correct, but that does not in any way benefit the patients. And the problem is correctly identified, the diagnosis is correct, but the patient actually has no benefit from the diagnosis. The main categories within overdiagnosis are misclassification overdiagnosis and maldetection diagnosis overdiagnosis. Misclassification diagnosis often occurs in situations where people use biomarkers or physiological variables or anatomical changes to make a diagnosis. It's just the problem is that you don't know where the exact threshold is, or you just take a threshold from another setting and you use it in your own new, different situation. Many of the diseases come from outside the ICU. There's a lot of them that actually are relevant inside the ICU. Acute kidney injury, hemodynamic insufficiency, etc., etc. Maldetection diagnosis is something completely different. It's the inability to differentiate between non-harmful situations and harmful situations. Despite the fact that there is a gold standard, you're not sure how you can discriminate the harmful cases from the others. And this is, for instance, common where you have ranges to diagnose a particular problem. So it's not over-treatment, it's not misdiagnosis, but it is potentially harmful to your patients, because an overdiagnosis may lead to treatment, which per se would be over-treatment because it's non-beneficial. Apart from the status of being a patient and all the psychological consequences that may have, and of course the financial implications as well. Now, overdiagnosis often involves having too much information. And of course, this is where we in the ICU have a particular issue. In many ICUs that use computerized information systems, tens of thousands of data points per day are generated. And of course, many of them are abnormal, and it's very hard within this huge sea of data to find what is really abnormal and what needs additional testing, etc., etc. So a lot of the results that come from our often routine diagnostic tests are often noise, and it's very challenging to find the actual information that is hidden in this noise. And the sad thing is that it probably won't become any better in the future. We'll have more data, we'll have more monitoring, we'll have more devices than ever before. So how is overdiagnosis created? There's a lot of the reasons why we get overdiagnosis that are relevant in the ICU. Expanded case definitions and the creation of pre-diseases, the lower classes of, for instance, acute kidney injury, the first the lower classes of ARDS could all be examples of situations where overdiagnosis is actually created. Very sensitive tests, and especially more and frequent or continuous invasive testing will lead to more overdiagnosis. There's a lot of examples, and pulmonary embolism is something we often diagnose in the ICU and really has a potential because our imaging is ever improving. The use of CT angiography has doubled the probability of finding pulmonary embolism. And they're not all, this is not false positive. So this is true pulmonary embolism, but maybe very small and just a single peripheral embolus. What do we do now? We're not sure. Sophisticated technology may help us, but it's probably also us. It's how we look at disease. It's how we look at a problem. We should be able to look at a whole picture and not just one little item. Apart from this, also our compulsion, our urge to diagnose and confirm what we have seen, our intolerance of uncertainty especially contributes to this as well. Overtreatment is a separate issue. This is therapy that is not indicated and not desired. And lots of examples in the ICU: sedation, antimicrobials, hemodynamic support, etc., etc. And I'm sure you can add many more to this line. So the problem also in overtreatment is the problem of normality. We have a set of parameters that we'd like to see normal. And if it's abnormal, we like to normalize it by assuming that bringing these parameters within normal range, that the patient would also improve. Doing nothing, not doing an intervention, is often difficult to explain to patients or to families, but also to colleagues and to nurses. It's often much easier to give an antibiotic, to start an antibiotic when you're not sure, rather than to just let's wait a while. Another problem is that we have a huge number of interventions that we can choose of. And rather than saying there must be an app for that, we can say for every disease, there must be a treatment for that. Whether it's beneficial or not, that's another question. This brings us really to this path of symptom therapy. We're treating symptoms and not diseases. Again, many examples in our ICU. If a patient has fever, we want to decrease the fever. If the patient is hypertensive, we want to decrease the blood pressure, etc., etc., etc. So we don't think about the disease, but about treating symptoms. So what drives us to do something? It can be personal factors, can be experience. If you don't have a lot of experience, maybe you're much more prone to do something. We like to see our actions confirmed, our diagnosis confirmed, and this urge to normalize that I just talked about. There could be, of course, organizational factors, routines, financial incentives, and the workload that pushes us to just do routine things and the patient pressures. You have a lot of negative effects, particularly when it comes to tests and treatment. Workload and cost is increased, and the effect on patient, of course, should not be minimized. Potential legal consequences are present as well, maybe different in country to country, but it should be considered. I'd like to end with just mentioning the ethical implications of overtreatment. It completely disregards patient autonomy and integrity, and per definition, it's not beneficial, increases pain and suffering, and harms society because you actually use limited resources for non-beneficial treatment. So in conclusion, ladies and gentlemen, when you do a test, always eliminate routine tests as much as possible. When you order a test, well, think first. And once the test is abnormal, please look at the whole picture. But this is even more relevant in end-of-life situations. But the central thing the central message I would like to give you is, at every step, ask yourself, does it benefit my patients? Thank you very much for your attention.